Good morning, colleagues. I'm really delighted and honored to be speaking at this year's Cochrane Africa Indaba, and many thanks to the organizers for inviting me. A quick declaration of interest. I'm the Joint Coordinating Editor for the Cochrane Effective Practice and Organization of Care Group, and some of the work I'll be discussing today has been funded by NORAD, the WHO, the Alliance for Health Policy and Systems Research, and the Brochure Foundation. Colleagues, what if the voices of relevant stakeholder groups routinely informed guideline adaptation processes in your setting? What if we were able to identify, summarize, and package evidence to help decision makers assess whether interventions are acceptable and feasible in their setting? And what if we were able to provide decision makers with evidence-based guidance on factors likely to influence the implementation of interventions and programs in their setting? In this presentation, I will argue now that we now have the tools to achieve all of these goals. In this presentation, I'll start by talking about what qualitative evidence is and also what qualitative evidence synthesis is. I will talk about the ways in which qualitative evidence can inform guideline development and other decisions. And I'll provide an example of how qualitative evidence could inform national guideline adaptation. I will end by talking about how we can make better use of qualitative evidence in national adaptation of guidelines. But first, let's start with talking a little bit about what qualitative evidence is and how it fits into evidence-informed decision-making. Qualitative evidence is evidence that comes from research that has used qualitative methods of data collection and of analysis. And this includes both primary research as well as secondary qualitative research, such as systematic reviews. Qualitative research, as many of you will know, generally aims to describe and explore people's views and experiences of the world around them. It is characterized by a naturalistic approach that accepts multiple perspectives and engages reflexively with the field of research. So what is the role of qualitative evidence in evidence-informed decision-making? The systematic use of research evidence to inform health and social care policies is now widely accepted. And systematic reviews of the effects of interventions and programs are now used routinely to inform policy decisions for health and social care. Of course, evidence on the effects of interventions is not enough to inform decisions on health and social interventions or programs. Even when decisions need to be made rapidly, such as in the context of COVID-19, decision makers also want and need information on the feasibility and acceptability of interventions, so as to better understand factors that may influence their implementation. Policymakers also want evidence on equity, gender, and human rights impacts, and qualitative research is a key source of evidence on these issues. But in addition to this, I would argue that that qualitative evidence plays an important role in representing citizens' voices. It can represent the voices of a broad range of citizens and stakeholders in decision-making, and is particularly valuable, I think, in representing marginalized voices, such as poorer communities and indigenous groups. The wider use of qualitative evidence may increase transparency and accountability in public decision-making, which may be particularly important during a crisis. I'd now like to move on to saying a little bit about the growing field of qualitative evidence synthesis. So what is a qualitative evidence synthesis? It's simply a systematic review of primary qualitative studies in a topic area and attempts to synthesize and analyze findings from these studies. The aims of these reviews are similar to those of primary qualitative research, as I described earlier. Qualitative evidence synthesis is a key approach for using qualitative evidence in decision-making, and this is because the approach can provide insights from the global body of research in an area. It can also help to highlight both similarities and differences in people's views and experiences regarding a health or social issue or intervention. And this in turn allows us to better understand variation across geographies, socioeconomic groups, sex, and so on. This kind of evidence can also highlight important knowledge gaps and so identify where further research is needed. So how can we use this kind of qualitative evidence in guidelines? Qualitative research can be used to define the scope of the issue being considered by the guideline. For instance, what problems, populations, interventions, and outcomes should the decision or guideline focus on? Secondly, qualitative research can provide evidence on how different stakeholders value different outcomes. For instance, we know that people of different ages may place different values on outcomes such as quality of life or mobility. Qualitative research can also provide evidence on the acceptability and feasibility of the interventions across different settings, and can provide evidence on equity, gender, and human rights considerations. For example, does the intervention increase inequities by gender or for people with disability? We can also use qualitative research to identify implementation considerations for a guideline, and these can be particularly useful for national adaptation of guidelines. Qualitative research can also support and inform national adaptation of guidelines or guidelines from other settings, for example, from a global guideline developed by WHO to a guideline adapted for use in Nigeria. So how might qualitative evidence help with guideline adaptation at the national level? Qualitative evidence on how different stakeholders value different outcomes may, for example, suggest that stakeholders in your setting place different value on the outcomes or see a different set of outcomes as important compared to the setting in which the guideline was developed. Secondly, qualitative evidence on acceptability and the feasibility of interventions may indicate that some stakeholders have strong concerns about the acceptability of the intervention, and that these stakeholders are also important in your setting. Qualitative evidence may indicate that the intervention may be less feasible within health systems models similar to that in your setting. With regard to equity, gender, and human rights considerations, qualitative evidence may suggest that the intervention may increase gender inequities in settings similar to your setting, or that minority groups in your setting may have difficulty in accessing or using the intervention. With regard to implementation considerations, qualitative evidence may highlight factors relevant to your setting that need to be addressed before the intervention can be successfully implemented, and may implement ways in which intervention implementation can be facilitated in your setting. A national group tasked with adapting a global guideline or a guideline from another setting can consider this qualitative evidence and decide whether, firstly, the strength of the global recommendation needs to be changed, for example, from a strong recommendation to a conditional recommendation. Secondly, whether the intervention should be recommended for a narrower group of people nationally, for example, for a particular age group. Or third, whether the intervention should be recommended for implementation only in certain settings where particular expertise is available, such as in tertiary hospitals. Let's move on now to look at an example of how qualitative evidence can contribute to guideline decision-making and to facilitating adaptation at national level. I'll focus on an example drawn from the recent WHO guideline on digital interventions for health system strengthening. The use of digital interventions within health systems is increasing rapidly in most settings, and this guideline considered 10 priority interventions in this area, using evidence to decision frameworks to assess different types of evidence. I'll focus today on one of these questions. Should the WHO recommend targeted client communication via mobile phone? Targeted client communication involves giving targeted information to specific groups of patients in the public by mobile phone, and this may include health promotion messages, reminders about health services, as well as diagnostic results. So what effects do these kinds of interventions have on healthcare utilization, health status, and health behaviors? A Cochrane review of effectiveness was undertaken to examine this question, and this found many gaps in the evidence, or low or very low certainty evidence for a range of outcomes. And the existing evidence showed mixed effects. There are probably some benefits for some outcomes, but it may make little or no difference to others. So overall, a fragmented picture with regard to the effectiveness of targeted client communication. So do people find these kinds of interventions acceptable? To explore this, a Cochrane qualitative evidence synthesis was undertaken, and this found that many clients are positive towards these services because targeted client communication provides them with support and connectedness to the health system, makes them feel like someone is interested in their situation and cares about them, and gives a sense of direction and reassurance. However, the synthesis also found that clients who are dealing with health conditions that are often stigmatized or very personal, such as HIV and AIDS, family planning, and abortion care, worry that their confidential health information will be disclosed. Is targeted client communication feasible in most settings? The same qualitative evidence synthesis found problems in many settings with network connectivity, access to electricity, system integration, and device usability that may impact on the feasibility of these kinds of interventions. What are the impacts on health equity? In particular, are certain groups of people likely to be systematically disadvantaged in relation to these services? The qualitative evidence synthesis that was conducted showed that these services may be particularly helpful to clients with caring or work responsibilities, clients who live far from health facilities, and clients with few funds, because it allowed them to access health care from a distance. However, access to these services may be particularly difficult for people with poor access to networks or electricity, people with stigmatized health conditions and concerns about confidentiality issues, people who speak minority languages or who have low literacy skills or low digital literacy skills, and people with poor access to mobile phones, particularly women and adolescents who may have to share or borrow a phone or may have their access to phone controlled by others, such as their father or their husband. So the WHO panel assessed the evidence to make a recommendation. In summary, this evidence was mixed or unclear in relation to the effectiveness of the intervention. It showed widespread acceptability, but some important conditions or exceptions. It highlighted a number of feasibility challenges in some settings, and the equity implications were mixed. So what did the WHO guideline panel recommend? WHO made a conditional recommendation on targeted client communication, suggesting that this intervention should be recommended under the condition that potential concerns about sensitive content and data confidentiality could be addressed. I'd now like to look at the implementation considerations that were developed for the WHO guideline based on the qualitative evidence, and explore how these could inform national guideline adaptation. The guideline suggested that implementers should, firstly, ensure that individuals know the messages are coming from a trusted sender. At the national level, implementers could decide that the messages should be sent, for example, by the National Institute of Public Health, if that is a trusted body. WHO also suggested that implementers should pay particular attention to the needs and preferences of people with low literacy. At the national level, messages could be crafted to include a pictorial format option to make them more widely accessible. Globally, WHO suggested that implementers should consider how the content can be tailored to the client, for instance by using their name or local information. At the national level, it could be decided to link messages to a new national electronic registry to facilitate client-tailored content and links to local health services. The guideline also suggested that stakeholders should be involved in the design of the program. At the national level, an advisory group could be established to advise on message content and format. And finally, the WHO guideline indicated that it was important to ensure that sensitive content or personal data transmitted and stored are held on a secure server. At the national level, it could be decided that clients would be able to select from a range of privacy options when joining the service. In the final part of this talk, I'm going to focus on how we can make better use of qualitative evidence in national adaptations of guidelines. As many of you know, developing a high-quality national or global guideline is a very resource-intensive undertaking, involving identifying stakeholders and fostering buy-in, agreeing the scope of the guideline, undertaking often multiple systematic reviews to synthesize the available evidence, packaging that evidence into a framework for decision-making, convening stakeholders in guideline development group meetings, writing, publishing, and disseminating the final guideline, and then keeping that guideline up to date. However, many countries have very limited resources and expertise for this kind of production of guidelines. I would therefore suggest that guidelines should be viewed ideally as global public goods, and this is because their benefits often extend to many countries, people, and sometimes also generations, for example, where guidelines are focused on maternal health. As global public goods, and because of the resources needed to develop them, I would argue that we should be producing guidelines through cross-country collaborative mechanisms, and the same arguments apply to the evidence syntheses that support these guidelines. In this local, global, collaborative models, guidelines should be produced in ways that facilitate adaptation, dissemination, and implementation at national or subnational levels. Collaborative networks, such as Cochrane and the Grade Working Group, play key roles in a local global collaborative model in my view. For example, Cochrane is one of the few organizations globally who routinely draw together and support teams to produce reviews on high priority health questions. Multilateral organizations such as the WHO are also central in this model, particularly in guideline development. So how does local global collaboration link with the evidence ecosystem? It's been argued that for health systems and services to function optimally, evidence needs to be transferred seamlessly between those producing primary evidence, primary studies, those synthesizing that evidence into reviews, groups producing guidelines and other evidence-informed decision support products, groups responsible for implementing evidence-informed options within health systems and services, and those involved in delivering and using health services, including service providers, service users, and citizens. We need to look at this whole evidence ecosystem in order to strengthen local global collaboration for guideline production and adaptation. So how can we build a local, global, collaborative and integrated evidence ecosystem? To do this, we need close collaboration between country-level evidence ecosystems and global ecosystems for evidence production and use. This may facilitate efficient use of our limited global resources for evidence and guideline production and use, and help to ensure that priority health questions are addressed. So how does qualitative evidence fit into a local, global, collaborative and integrated evidence ecosystem for guideline production? I have tried to show that we now have most of the elements of an ecosystem for qualitative evidence in place. Evidence from primary qualitative studies are feeding into evidence syntheses, and these syntheses are being used in decision products such as guidelines, although perhaps not as much as we would like. Guidelines informed by qualitative evidence are being used to guide choices on clinical and health systems options. And qualitative evidence is starting to inform guideline adaptation. Finally, these new initiatives are being evaluated through new primary qualitative research studies. But of course, there are some important constraints. Firstly, the capacity to undertake and use qualitative evidence syntheses is limited in many settings, particularly in low and middle income countries. Second, even more limited is experience in integrating qualitative evidence into guideline processes and using qualitative evidence to inform guideline adaptation at national and subnational levels. And third, there's also limited awareness and demand for qualitative evidence among policy users in some settings, although I think it is the case that policy users have many questions that can be answered using qualitative evidence. So how can we mainstream qualitative evidence within a local, global, collaborative and integrated evidence ecosystem for guideline production? I will talk about 5 aspects that we might consider. Firstly, how do we institutionalize qualitative evidence use? We need to incorporate qualitative evidence into the frameworks we use to analyze political, health and social systems, as well as to structure and package evidence to inform decision-making and guidelines, so that we can systematically use synthesized qualitative evidence when policy windows become available. Secondly, we need to engage with multiple levels of decision-making from national to local and with different stakeholders and groups. Third, we need to network. In particular, we need to establish national cross-sectoral networks of qualitative evidence producers, knowledge brokers, and their decision-maker partners, and link these networks across countries to share experiences and tools, strengthen capacity, and mentor. And I would argue that we need a culture shift. We need to build a culture of using qualitative evidence to inform guideline development, adaptation, and implementation, taking into account different cultures of evidence across settings and different approaches to what constitutes qualitative evidence. And finally, we need to strengthen organizational capacity. This involves increasing awareness of what qualitative evidence is, why it is a valid and trustworthy approach, and how the findings of these syntheses can be used in decision-making processes. And we need to strengthen capacity in existing knowledge translation platforms to find, appraise, and use qualitative evidence to support guideline adaptation. I think that knowledge translation platforms can play a key role in supporting the use of qualitative evidence for guideline adaptation as part of an ecosystem for qualitative evidence. These platforms can help to build demand among policy users for qualitative evidence, can support the use of qualitative evidence in guidelines, and can support dissemination of guidelines to implementers and other stakeholders. I would like to end this presentation with a challenge to those attending this conference. In my experience, the best way of learning is doing. We all need to look for opportunities in our settings to strengthen capacity to produce qualitative evidence, including primary studies and qualitative evidence syntheses, and to support the wider use of qualitative evidence to inform guideline adaptation and other decision processes. In this way, we can help to ensure that the guidelines we adapt and use are relevant to the needs of key stakeholders, including healthcare providers, service users, and citizens. Thank you very much, and I look forward very much to the discussion and questions later.